Hello, I'm Dr. Jonathan Silverberg. I'm a professor of dermatology at the George Washington University School of Medicine and Health Sciences in Washington, D.C. And I'm presenting the efficacy and safety of upadacitinib versus dupilumab in adults and adolescents with moderate to severe atopic dermatitis, results of an open label efficacy assessor blinded head-to-head phase 3b4 study called Level Up. So for background, I think we're all familiar with atopic dermatitis and the burden that it has. But we understand that for many patients, even when they're doing well with different treatments, they may not be doing well enough. And even patients who are getting moderate responses with different therapies, may need more. Previous studies have shown that having any itch left over after a treatment really comes with significant impacts on sleep and quality of life, etc. Now, there are multiple therapies that are approved for moderate to severe atopic dermatitis. We have upadacitinib as a selective JAK1 inhibitor. We have dupilumab as a biologic that targets interleukin-4 receptor alpha subunit, and other therapies. But we so rarely get, in the world of clinical trials, head-to-head trials that allow us to compare how multiple approved therapies are performing. Now, another important issue, and maybe one of the most important issues that was sort of the rationale for this Level Up study, was that in previous studies, Measure Up 1, Measure Up 2, and other studies for upadacitinib, the way it was studied was in two different doses, 15 milligrams or 30 milligrams. And when patients got those doses, they got them from the beginning of the treatment period all the way through to the end of the treatment period. Now, when the FDA approved upadacitinib in the United States, their recommendation was, well, start with that lower 15 milligram dose. If patients do well, great. If not, then they can be stepped up to that 30 milligram dose. The challenge was it actually wasn't studied that way in the clinical trials. And so we had an important data gap to know, well, how well does that 15 milligram on-label step to 30, if needed, regimen perform? And so this is the background for the Level Up study. The Level Up study assessed this on-label dosing of upadacitinib, 15 milligrams once daily as that initiation dose. And if they did well, great. If not, they could be stepped up to 30 milligrams, as I'll explain on subsequent slides. But beautifully here, we have a head-to-head study against dupilumab. So we get to actually see that comparative efficacy. And very importantly, this study is really quite provocative because it set its primary efficacy endpoint as a composite endpoint of patients who achieve both an EASI-90, which is a 90% reduction in the Eczema Area and Severity Index, which is a major clinical improvement in the EASI score, and an NRS itch of 0 or 1, which would essentially be getting to itch-free. And so patients, to be considered, hitting that primary efficacy endpoint, they'd have to achieve both of these endpoints concomitantly at week 16. All right, so that's the background for the study. Let me walk you through a little bit of the design. So Level Up, it's a phase 3/4 randomized open label study. So the patients all knew what they were getting. If they were getting upadacitinib, they knew it. If they were getting dupilumab, they knew it. But the challenge with that is if the patient knows, or it's one thing, but if the investigator or the assessor knows what the patient is getting, that may introduce bias in how the assessments are done. So this is an efficacy assessor blinded study. The assessor of those outcome measures was not aware of what treatment regimen the patients were on, and that was done to reduce bias. This is a head-to-head study, and it's multi-center international study that looked at adolescents and adults with moderate to severe atopic dermatitis who had an inadequate response to systemic therapy, or when use of those systemic therapies was inadvisable. And that's really the on-label recommendation for dosing and treatment with upadacitinib. The patients would be randomized to get either that 15 milligram starting dose or dupilumab with the on-label dosing for 16 weeks in that initial treatment period. And then there was an additional 16-week extension period out to week 32, which we're not going to be discussing the results of today. Importantly, and this may be one of the most important sort of design features to be aware of, is that the patients were initially started on the 15 milligram dose. but the dose escalation could start at week 4 if the patient had not yet achieved an EASI 50 response, which would be a minimal improvement in the EASI score, or a 4-point reduction in itch, which is about a moderate improvement in itch. So if they didn't get either of those endpoints by week 4, they could then be stepped up to that 30 milligram dose. Even if they did achieve those endpoints by week 4, if they did not achieve an EASI 75 response, which is a more moderate improvement in the EASI score by week 8, they could also be dose escalated to 30 milligrams. Now, rescue with topical therapy was optional and per the investigator's discretion, starting at week 4, and as well as 4 weeks after dose escalation to the 30 milligrams of upadacitinib if needed. So when we think about the efficacy, the baseline characteristics of the patients, first, this is a very large clinical trial. We have over 900 patients who were randomized, about a 50-50 split between upadacitinib and dupilumab. In terms of the baseline characteristics, they are overall balanced across treatment arms, indicating that the randomization worked well. And we have a good mix of both moderate and severe patients, but really sufficiently moderate to severe patient population. Overall, just to summarize the results, upadacitinib showed superiority, statistically significant superiority for really all of the primary and ranked secondary endpoints compared to dupilumab. But in particular, when we drill down on some of the key endpoints, first, we're looking at the primary endpoint. We see that almost 20% of patients with the upadacitinib 15, on label 15 with the option of stepping to 30 regimen, almost 20% of those patients achieve this very rigorous composite endpoint of EASI 90 and worst pruritus NRS itch of 0-1, compared to less than 10%, actually less than 9% of the patients in the dupilumab treatment arm. Now that's at week 16. When we actually look at the kinetics of those responses, what you see is that upadacitinib is also markedly faster in terms of starting to achieve that response already by week 4. And statistical superiority was achieved compared to dupilumab already by week 4. And that separation from dupilumab continues to widen out at week 8, week 12, and continues out to week 16, which was the primary efficacy time point. So that's the primary endpoint. When we look really at all of the other endpoints, like EASI scores, and there's many different ways you can cut the EASI scores. EASI 75 is a moderate clinical improvement. EASI 90 is a major clinical improvement. EASI 100 is clear. And what we see is for all of those endpoints, upadacitinib showing statistical significant superiority compared to dupilumab. And the more robust the endpoint, meaning there's a nice separation for EASI 75 between upadacitinib and dupilumab. But when you go to the EASI 90 score, that separation widens even more. And when you get to the EASI 100 score, you have almost 3 times as many patients in the upadacitinib arm that are achieving this endpoint of EASI 100 compared to placebo. And when you look at the kinetics of those responses, you also see, that upadacitinib is markedly faster in achieving these endpoints compared to dupilumab, really for all of the endpoints. Although in general, right, it takes a little longer to get an EASI 90 and even a little longer to get an EASI 100, as we would expect. But at all time points and at all endpoints, upadacitinib showed superiority. When we look at itch, we know, of course, itch is so important to patients, in this disease and so many other diseases. But when we look at the proportion of patients who get to that NRS itch of 0 or 1, that itch-free state, what we see is already by week 2, upadacitinib shows major separation from dupilumab and statistical superiority, and that efficacy just continues to grow for itch-free out at week 4, week 16. And when we look at the proportion of patients who have a 4-point reduction in itch, we see very rapid onset of responses for upadacitinib and superiority compared to dupilumab across all time points. Now, one of the biggest challenges I think that comes up clinically is that sometimes you have, with any drug, you can have a subset of what you might call super responders. The patients just do fantastic. And sometimes other patients, not as much. And so we always are left with that, like, well, who are the super responders? And trying to understand that, and how to better pick those patients who are going to have that fantastic response with a particular therapy. So we did a post hoc analysis to really stratify treatment response, the proportion of patients who get to this EASI-90 and worst brightest NRS itch score of 0 or 1, that composite primary endpoint, and stratified by baseline severity and other characteristics. And what was fascinating was that upadacitinib showed statistically significant superiority over dupilumab, but worked just as well across all those different treatment groups, right? So it worked just as well in severe patients as it did in the moderate patients, and maybe a little bit better efficacy in the adolescent, the age 12 to 17 group, even more efficacy seen there. But really, even across young adulthood and older adults, we're not really seeing any major differences in terms of treatment response. So it really suggests that upadacitinib works quite consistently across all of these different groups. From a severity or from a safety perspective, overall, we've seen no new safety events, no new adverse events that we didn't know about previously from the previous trials with upadacitinib or weren't class-wide considerations. There were no deaths reported in either treatment group. Overall, severe adverse events leading to discontinuation were pretty similar between upadacitinib and dupilumab. And when we look at sort of the individual items, the individual adverse events that come up, there was one serious infection reported for dupilumab, but none for upadacitinib. There were several opportunistic infections that occurred with upadacitinib, but not for dupilumab. There was, higher events for herpes zoster or shingles and elevated CPK levels with upadacitinib versus dupilumab. The recommendation for, in general, for upadacitinib use would be to get patients vaccinated for shingles. CPK elevations are not recommended as part of the clinical guidelines. And fortunately, no malignancies or adjudicated major adverse cardiovascular events, venous thromboembolisms, et cetera, were reported in either of the groups. So the take-home message is that treatment of moderate to severe atopic dermatitis with the on-label, upadacitinib 15 milligram initiation dose with the option to step to 30 milligrams, based on the clinical response, showed statistically superiority compared to dupilumab, really for all endpoints, but particularly for that primary composite endpoint of EASI-90 and worst pruritus NRS itch of 0 or 1. And the superiority of upadacitinib versus dupilumab was demonstrated as early as week 1, but really for itch, week 2 for lesional severity, and continued all the way out through week 16. No new safety signals identified in this study. And I think it really highlights for us that we have the opportunity now for some patients to be able to achieve this really stringent, endpoint or composite endpoint of getting them clear skin and itch free, which of course is what our patients want. And so I think it really, helps to sort of guide us in how we now think about setting the bar in clinical care for our patients. Thank you very much for your attention.